Bing, we are begun. Now I will demonstrate to you. In the content area below week 4, I just added, I made this outline up, I mean, years and years ago, but I'll hit myself on the back too many times. I mean, I've spent 25 years plus doing wounds. So, I mean, I was doing wounds before I got my doctorate. A lot of the other programs that I did. So wounds are something I'm fairly familiar with. So I have a lot of information. It's just good to look at wherever you're going to go and wherever you're going to be doing it. I mean, just look at the dog and cat stuff because that all comes into play. Okay, and this is the PowerPoint we'll be using. I don't think there's anyone. I'll talk about it in passing in certain chapters in the Cowan textbook, but at least this is more clinically oriented. This chapter 23, and you'll find, and I have loaded them both. This is a quick look-see at the outline. You can see it's. Let me just pop that thing out of there. All the different, and I'll just go over this, and you can read it. And again, a lot of the things I'll be telling you, if I haven't covered them all, you'll be able to read them here, and a few extra little tweaks as we have seen things turn on. And I think today is Tetanus Day. When we start really talking about that a little bit in earnest, just the severity of that's there. And I think we'll deal with 3 different types of gangrene, animal bites, etc., etc. And hopefully get done with this by Wednesday. I could probably leave Friday for a review day, if possible, or at least some of Friday is a review day. For those who are still attending and not in Friday Club, and you know who you are. So Monday we get to see you. It's good to see you out there. Happy? You're always here. It's not bad. I mean, we got like 19 out of 26. It's not bad. Or 25, whatever the number is now. Not that funny. No laughing.
What if I'm laughing at you?
You're laughing at me?
Not at you, like just you, but just
because you're trying to compliment
me. You're just so funny.
Yeah, tell me about it. Funny, peculiar, not necessarily funny.
Wow. You're funny,
Yeah, 2. Damned with faint praise. See, I know it's early for the foursome over there who are not smiling. It's something I said. Go ahead, send me a review. See if I look at it. See, I'm not so think as you dumb I am. Oh, thank you. My wife's poison ivy is thankfully starting to improve after a horrible week. And let's begin. Enough. Okay, wounds number 1. I mean, it really starts with where you're going to learn that we have 2 classifications realistically for those of you who are, depending on where you are, but typically in an emergency or an urgent care situation, wherever one might find themselves, or just somebody. Believe me, for many of you, when you get into a healthcare field, if you're going to be in nursing, people are going to know that where you live, and something's going to happen. They're going to come to your house. They're going to run and knock on your door. Oh my God, blah 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 blah. You know, the time to begin to understand is that's part of having a professional degree and a professional certification and a professional license. Is all of a sudden you know more than they do, and you have some degree of authority on the subject. So this is really important, and this is, we said it's everywhere from the first lecture. End of sports. So this was one of Koch, you remember his associates. He was studying in Koch's laboratory, this gentleman, and found that in soil and dust. He determined it was an obligate anaerobe. He figured out how to cultivate it. Not so easy to deal with anaerobes. In the old days, you used to get a candle jar, glass jar, lit a candle would suck up all the oxygen. You could cultivate it in there. That's what he did. Still used. Discovered animals injected with this developed tetanus, but no bacterial cells found elsewhere in the body. Interesting. Showed the toxin was responsible. Similarly demonstrated diphtheria is caused by a toxin. So the culprit is the toxin. And we classify all wounds as this: tetanus prone or non-tetanus prone. The vast, vast, vast majority are non-tetanus prone. I've said it to you before, that question that you ask when you're doing an interview, when was your last tetanus shot? It's much more about, you're going to be giving tetanus shots to people who have a routine laceration, a cut relatively superficial on the surface, requires a handful of stitches. See you later. It's not a tetanus prone wound. Typically, it's the person versus a sharp kitchen knife or sharp kitchen object. That is not a tetanus prone wound whatsoever. Why do we do it for that time when they're out in the woods, their car breaks down, they're in an accident, and there's a lag time before they get adequate help, wherever they might be? It's for that one that you're concerned about it when it is a tetanus prone wound. And we have, obviously, you're going to see tetanus prone wounds, but typically those are significant accidents. Those are accidents that are outdoor. They're out like they are this time of year when you're out in your yard or something happens with that. I mean, there's a zillion scenarios, and we'll look at it, but that's coming up. That's sort of the introductory piece. So any break in the integrity of the skin, any exposure or break in the mucosal membranes, we're allowing microorganisms to enter. Not just the normal flora, but but all the others. So, and this is why. We talked about this. Virulence factors. I mean, basically, how many entered? Is a person compromised? Is it a nasty wound? This is a nasty wound. This is undoubtedly a wound that was limited. And what happens once you start to get infection in there? And I don't know where it's located. And you can see that yellowish material that's there, the reddish, the inflammatory changes. That's bad news. Layers are starting to undermine. Infections are lazy. Typically, they spread sideways. You all did dissections, or you observed the dissections. I don't enforce people dissecting, but you all should have been watching those. And when you dissect, they're planes. You separate something, you could take your finger, you could take the blunt end of a scissor, of an object, the blunt end of a scalpel, and we all dissect by that's called blunt dissection, and separate the layers. Those are tissue planes. That's how infections spread. Sideways. When that happens, all of a sudden the edges get undermined. It looks like the skin's puffing out, and oh, it's nasty. And those things spread like wildfire, depending on what they're like. So, is it a wound? Foreign matter, biofilms, blah, 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 all of the above. So, and now once you see a wound that's infected, that went from being a non-tetanus prone wound to a tetanus prone wound. Because when things are affected, ladies and gentlemen, they undergo a process called necrosis. Tissue dies. And if it dies, it doesn't have a blood supply. If it dies, then there's oxygen not getting to it. It's anaerobic. And that's why when wounds came into the emergency room, we flushed the heck out of them. We did a process called lavage, where the name lavatory comes from. We're washing out. We take big bulb syringes, giant sterile turkey basters, for lack of a better way to express it, and you start flushing that out with water, with saline, with betadine dissolved in the water, whatever you got handy, because you want to wash it out. We do the same thing in surgery. I mean, we'd operate on somebody after one of these things. We'd hang their leg or their arm within the sterile field. Somebody would hold it, and we'd take gallons of sterile water and saline and put a bucket underneath it and start pouring it in. You got to. I mean, it's not just dabbing it. So understand that there's a lot that I have to share with you about this. As long ago as it was, it hasn't changed. To think that 50 years ago doing this in an area we had, I mean, I told you, it's in the movies. Gunshot wounds, stab wounds. The door, a car would drive up, just like in the movies. The double doors would open. Somebody get out, throw them in, the car would take off. No questions. People with bones sticking out. People screaming in pain. If you're watching The Pit now, and you should be, that's the kind of crap that happens. It doesn't make it any different. Society hasn't changed that much. It's just perhaps got more violent, if possible. So we classify them. Is it an incision? Okay, if it's an incision, and if it's the typical, I got a cut. Oh, I might need a stitch or two. That's basically a simple incision. It would classify as a laceration, but laceration to me we call them lacerations documentation-wise. But the reality is lacerations imply that tissue is torn. Punctures are bad because effectively you're inoculating potential infective material under the skin. Once it gets under there, it's like a splinter that doesn't come out. Now you have the potentiality of infection sequestering itself, walling itself off. So punctures inherently, if anything, we want to open them a lot, if possible. Sometimes that's part of the strategy. Sometimes there's a whole lot of strategies. Just came to mind when someone comes in with a simple laceration or a post in a surgery where we make a cut in the skin and we close it. It's called closing. I don't know if even still is my first intention. Our intent is to close it quickly and anatomically, bringing the layers together, stitches, staples, whatever. Secondary intention means you just let it fill in. There's such a risk with a big open wound like that if you closed it over the top, it would get fluid, and if you didn't get everything out of there, it would just turn into a wildfire and go all over the place. You let it fill in. You know it's not going to be cosmetically particularly appetizing, but that's why the good Lord made plastic surgeons. So you understand. And that's what you go, hey, look, down the road, 6 months, a year from now, let plastic handle it. They'll figure out something to do with it, make it pretty up. That's secondary intention. And sometimes we call it tertiary. Tertiary intention. We let it fill in until we were sure that we didn't have infection, and then we close it. Then we bring it back. So that's, I mean, those are all little, they're sort of tricks of the trade. You really have to watch. Some things you don't want to close. Wait till we get to animal bites. You rarely put sutures in animal bites. Only sometimes you're using what are called retention sutures. So you're trying to improve what's probably going to require some type of cosmetic surgery intervention down the road. Just for instance. So a contusion's really, it's a wound, but it's inside. Doesn't mean there can't be damage, there can't be bleeding inside, but there's no break in the integrity of the skin. Wow. And that has their own subset of problems. When you damage tissue like that, you can have localized bleeding in the area. Too much blood can obstruct or squeeze blood supply to other structures. It gets a lot of swelling. Sometimes you almost have to open it up to let out the fluid that's in there. I mean, there's a lot that goes on. Well, you and I get a lot of our abrasions. We scrape our knees. We take a tumble, that type of thing. Little kids get them all the time. They ouch. But by definition, most of the time, it's just epidermis. And it's relatively easy to treat topically depending on the size. And we all do the same thing. You clean it off, whether it's just soap and water, whether you dab it with peroxide, put some topical antibiotic, cover it. If they're going to go back out and play again because they're kids, they're going to do that, or anybody else. And when they're home, I mean, a little airtime is not necessarily the worst thing. Sort of maybe in the middle of all of this is a good time to talk about the philosophy of wound healing. Years ago, depends on how up to date, and hopefully all the nursing instructors are up to date with this. I do not know. I am not going to get into a debate with them. This is one of those, Dr. Stein said this is medieval. Just look at them and go, yeah, thank you for pointing that out. I'm happy. I will do that. They used to call them wet to dry dressings. The idea is you have a bunch of yuck coming out. We're going to put a little saline on this, sterile saline, 4x4, put it on there, let it dry, wet to dry, or put some betadine on it, wet to dry. The next day we'll just tear it off. Probably something from medieval torture chamber, as much as that hurts. It would hurt. Imagine how you ever get dressing with stuck piece of tape. Perfect. Just waking you up. No glasses today? Got your contacts in?
I don't have contacts or glasses. I'm stressed out.
Stressed out. That answers the question. So don't laugh. I haven't teased you yet, but I'm working on it. Okay, moving on. So the idea of wound healing is keep wounds moist. Sometimes you do need a period of time. Maybe if you're starting to see improvement, letting them dry to the air is not necessarily a bad idea. It just depends on what the person's doing. If they're going to be relatively sedentary, maybe a little bit of airtime. It's a fine marriage. Okay, there's a lot of sort of what I call cookbook medicine. We all do. a little bit of this, a little bit of that, all those things. But generally, the theory is keeping them moist. You'll learn about wound vacs to pull fluid out of them. I mean, the idea of leaving something dry, little baby cells are filling in that area. The worst thing you can do is dry them out. They need moisture. They're living things. Unless I missed what I told you the first day in A&P, water is essential. So this notion of the wet to dry dressings is just ooh. And we used to do them. We'd incorporate them in surgical dressings, post-operatively. But thankfully, we would put a piece of Vaseline impregnated gauze so it would not adhere directly to the wound. It made it a little easier. And if you see some surgical intervention, you'll see that. So okay. Another misnomer about projectiles. Interestingly, it's like if you watch old movies on TV and somebody gets shot, what are they going to do? Where are we going to dig out the bullet? No, you don't. If the bullet's in a bad place, that's a different story. You'd have to determine that by x-ray or by location. But digging out the bullet is not the answer. The bullet actually sterilizes itself as it works its way in. Okay, it's a high-speed projectile. Believe me, it's not carrying any passengers along with it. I mean, and whether it's a hollow point or a full metal jacket and all those. In other words, if you're familiar with that type of stuff, hollow points explode inside their danger. They fragment. Full metal jacket ones, which you use for practice target shooting, go straight through. You want to hurt somebody, you use the soft tips, the hollow points. Nevertheless, the whole idea is, where is it? I mean, if it's near a vital structure and you're afraid it's going to move, that's a different story. You might go hunting for that. But we never did that. Okay. We had a guy who was, and bullets do crazy things. We had a guy, it wasn't the first time he was shot. It was crazy. He was shot here, and it must have deflected off maybe a low rib or part of the sternum and ended up back here. He'd missed everything vital. He had a few nicks here and there. Oh my God. It's crazy. It was shocking. And then we had another guy with the same thing, and it hit. Okay, it went all the way around. We didn't know this, and it nicked the inferior vena cava, which is deep. You have to move all that stuff. Inferior vena cava is way against the back wall. It's the largest of all the blood vessels by diameter. And we're opening this guy up to do an exploratory. Okay, Lou, you're going up here because I'm making rounds with surgery, general surgery. We got to go up and operate this guy right away. Tell the R, bring him up. We're on the way. Oh my God, we're in there. It's just the two of us. He's doing the operation, assistant chief, one of my mentors, and I'm holding retractors. It's like, and he's going, wonderful fellow from Argentina. And he talk to himself and teach while we're doing that. And at one point, he sees something he did go, I don't like this mass. Because he looked at the bowel and he sewed it up and he pushed it aside. He goes, I don't like this at all. And he started to explore it, and all of a sudden it started to leak. He goes, Lou, get someone to hold the retractors. You put your hand right on it and push as hard as you can. Okay, I can take yes for an answer. I said, now what? He goes, just wait. Call the vascular surgeon. Well, we were a small hospital. The vascular surgeon was on call. You had to be 20 to 30 minutes away. What did I do for the next 20 to 30 minutes in the operating room? That's right. I said, what happened if I let go? He'll die. Okay, got the picture. True story. And so finally they got in. I'm holding it, gloves, gown, the whole thing. Yeah, that whole go to the bathroom thing is not happening, by the way. Did I tell you how you go to the bathroom if that has to happen when you're doing that stuff? One of the other staff people will drop them for you and put a urinal. I don't even know what they do for the gals. But for the guys, at least it's a little easier to handle. Truth, absolutely never happened to me. You push that down and holding it. Finally came in, sewed it up. I swear to you, the next day we went to make rounds. Within 24 hours, the next time we were together making rounds, he's up, holding IV. And it wasn't the first time we shot. Just to give you an idea, bullets do funny things in people. Now, how that related, it depends on how familiar you are with weaponry and things like that. I'm not. I don't own a gun. But I mean, if a Saturday night special is 25 caliber and 20 are small, it's easy to get things moved around. They don't do it. They do a lot of damage, but not necessarily. Depends on where they hit. And then we're going to talk about burns, and burns are thermal wounds. Thermal injuries or thermal wounds are very simplistically stated. I mean, something has happened to cause the death of epidermis and/or dermis, and/or deeper, whether it's heat, electricity, chemicals, radiation, or friction. I will come back when we look at gangrene, and I will tell you about it resulted from effectively a thermal injury, frostbite. Interesting. That's coming. So, and this is it. Without going crazy about the names, what happens when it's a protected tissue? We're not supposed to have microorganisms. That is a sterile internal compartment. We know now that we see microbes in some funny places. We thought it used to be sterile, but these are places where it should not be. I mean, the collagen, the most abundant of all the proteins. These are other ones that are various kinds of glycoproteins, fibrinogen certainly in the plasma itself. Okay, we do not want them exposed to these things. They're going to damage and destroy or alter those mechanisms. And what happens, wounds, just like I said, you see a wound, I know my own. Get over it. When you see a wound of any type, again, they basically heal from the bottom up. From the sides, cells migrate in. From the bottom, that's why it's so important. You have a nice bed and let the cells migrate in. That's the problem with closing it over, like I said before. Fluid accumulates and it can go sideways. So you want them to heal more often than not, unless it's an extraordinarily unusual wound. Sometimes you have to go in there and clean that out. And if you're confident, like in a surgical scenario, where you extract it, then you can close it in layers. If you're taking out, like I do, taking out a piece of bone or a piece of blow this many years ago. So they come in, blood supply, fibroblasts, we call it granulates, that's red, healthy tissue. As long as it's nice and healthy and pink, that's good. The minute it turns yellow and gray, now that's something that eventually we have to use means to get rid of. Preferably, you're going to see a lot of it done. This is another one of those barbaric things, is to breeding them sharply. Taking scalpels. Well, we got a bunch of junk in here. We have to get it out. There's better ways. That's where advanced wound healing is today. We have a lot of materials that we can put in, mixtures of things, and that the wound, for instance, for those in nursing, a wound healing nurse is a really important job. We get a lot of extra training. My first wife did that. I was in a nursing home. I mean, I have a lot of ulcerations, bed sores, particularly. You'll learn. You go to seminars. You learn about the techniques. You educate the staff. That's what she did. Incidentally, she are into the BSN. Just say it. Hopefully, making my point. So you got to be the nature of the debridement or debridement, however you want to pronounce it, is very significant. And that's everywhere when it comes to wound. You got to get rid of the bad stuff. And they're just showing you how this is. I mean, they're going to feel it's just allowing it and hoping it feels. Sometimes by intent, we will pack things and we'll let them. We pull a bunch out and we'll pack it with sterile gauze and gradually advance the gauze. Effectively, you want it to heal from the bottom up. That's maybe the easiest way to express that. When it's infected, we have an abscess. An abscess is a localized collection of pus, inflamed tissue. Typically, the pus has the different colors tell a story, but typically, when we talk about thick yellow, we're talking about Staphylococcus aureus. Remember that big AU? Why we name it that way? Golden yellow pus. See, it comes back. And what's in there is not infectious. This is my favorite pet peeve for you folks, because they're going to have, this is going to be in order. Get a culture about that. Do not culture the pus. I mean, if they want you to culture the pus, that's fine. The pus is filled with dead stuff, dead bacteria, all that, living and dead white blood cells, debris, proteins. Did it mention bacteria in there? I think not. Basically, the bacteria are along the sides and particularly the base of the wound. Sometimes you have to go in there, take a sterile gauze pad, get rid of some of that stuff, and swab deeply. Oh, that's going to hurt. Okay. Get an order to pre-medicate them if it's going to hurt a lot. There's no sin about pre-medicating somebody. No. To give them a shot of whatever they're using in today's hospitals. If you have to go in and do procedures at bedside, you're not supposed to torture people. I mean, you're going to learn about this and what the protocols are wherever you work. But that's the nature of those things. You go hunt out a resident, be nice, and say, hey, give me an order so I can do this for you. Depending on the situation, a little different if you're in an emergency room situation. Okay, from the body's defense, they localize. It's supposed to form this, if possible. But again, if it doesn't have a pathway out by leaving a wound open to drain, it's going to spread sideways, and that's why a lot of times, in order to do this, we have to incise and drain. What you're doing is basically what you did in the lab. It's called a culture and sensitivity. You have to identify the bacteria. You have to identify what it's sensitive to or what it's resistant to, just like you did in the laboratory, and that's how you come up with it. What happens in an urgent situation like an emergency room or urgent care, you make an empirical choice. Okay, I mean, if I see something that looks like staph, it's most likely staph. I mean, depending on the facility, you can usually get a gram stain done pretty quickly. You won't necessarily be doing it there, but the lab, depending on how busy they are, the word we use is stat. You're familiar with the lingo? What stat means? Right away. By definition, anything from the emergency room is stat. I need these blood tests. I need this culture. I need this gram stain ASAP. Culture is going to take 24 to 48 hours. But they can do the preliminary test just like a urine. Okay, I can do a quick micro on that and see what's going on. We can dipstick it. Because you need that information. Information is pointing you in the right direction. Okay, you got to start. You have all these things, and the other thing I should tell you when we're dealing with it, again, the focus point, and that's where whoever's doing the medical advice. The key issue is identify what could kill them first. Once you rule out something that is inherently they could succumb from immediately, then you've got time. You have an extra port of time. Well, I mean, that's an interesting wound. Oh, a piece of bone sticking up. Are they having a heart attack? So that's kind of the way we were taught. And I can't imagine it's any different. It's a kind of triage. And triage means basically when someone comes in, can they sit in the waiting room for X amount of time? Or do we have to take care of it right away? Okay. It's difficult. It depends on where you're doing. That's typical triage here. I mean, it's different in wartime. Triage is want to get the healthy guys and gals back together first because we got to go fight. People who are dead and dying, interestingly enough, have to wait. Awful, but true. Okay, and all of these things, difficult to treat, lack of circulation, okay, all of these types of things. That's why we try to find a way to get rid of it. So most antimicrobial medications are ineffective in this scenario. So abscesses usually must burst to the surface or be drained. And the name we give it to is I&D, incision and drainage. You don't want to be making a little nick. You want to open that bad boy up. And so normally you saw this before. Normally, this is the way you would hope it comes out on its own, but you don't always have the luxury. And wounds, depending, it's hard. Most of the time, there's a special way to culture things anaerobically. And a lot of times you'll have to do that as well. That'll be a special culturette, which is like a Q-tip that you put inside to a special broth. They have anaerobic culturettes, so because the organisms die in the air, you've got to find a way to get the culture without them dying in the air. So taking a Q-tip like you would in lab, and like rubbing it across the top of a culture plate, for example, and you're going to inoculate it in something else, now all of a sudden that anaerobe is now exposed to air. So there's different ways, and you'll learn about those things. This is the problem with wounds. Destroy tissue, allow the growth, and tetanus is everywhere. The more extensive the damage, all of these contaminations, that's why washing them out. And we haven't even talked about polymicrobial and infections that have more than one culprit. associated with them. And so, again, they can produce anaerobic conditions, aerobic, facultative, etc. So here are the big players that happen. Toxins going elsewhere, big problems, abscesses, all of these things, whether it's from implanted, that's my frame of reference, things that go on, because unfortunately we're so concerned about those being infected, because your choice when they're infected, unless you're very fortunate, is to remove them. Now you have a mess on your hands. You already taken away bone, let infections heal, the bones, it's a nightmare. So these to me are the most common ones we see. Staphylococcus aureus, and also hospitalized because of compromised hosts. You had Staphylococcus epidermidis. Strep pyogenes, Pseudomonas. You're going to get sick and tired of hearing about this green guy called Pseudomonas. Even though it's came enough under the right circumstances to work in well. So what the infections we see most commonly in the hospital, you're going to see a fair amount of this. Methicillin resistant, Staph aureus, this one, methicillin resistant. It's still staph, because it's normal flora doesn't mean staph epidermidis. So I would categorize all my infections based on cultures, MRSA or MRC. And we also have MSSA, and I categorize them this way. Methicillin, systemic. So on a chart, that made it work for me. Whether you have to do that kind of charting or not, I do not know. But effectively, that's one of the first things. I mean, that was a very useful classification based on it. So when you look at a chart, you understand what they're going through, what antibiotics, why they're on a particular one, etc. It depends on the position. So, for instance, when my wife went on Monday when I came, I reluctantly she'll go to the doctor it's like it's like one of the cats screaming in the little cat carrier going to the vet. She does not want to go. I don't want to go. Doesn't like doctors. So that was she treated by an urgent care by a nurse practitioner, and that made the physician some of you. So this is not something. It's not. There's times when you're going to be responsible to do all these things. Everywhere, it can be your own leading cause of wound infections, not even close. Pus producers, inflammatory spreads, and now and we see it more from wounds now, certainly not like years ago with tampons, toxic shock syndrome. And again, that is a super antigen reaction, activating all those helper T cells with immense amounts of cytokines causing the problem. And it's just when they say the word shock, it's just that. And so is this the kind of wound? This is a wound that had started to heal but opened, wherever that is located. I mean, it's hard to tell from the pictures when you're seeing this. And I mean, and there's all sorts of neat little clues that begin to tell you these things. Toxic shock syndrome, again, and we're going to look at necrotizing fasciitis shortly. All of these, you have to have an index of suspicion. I guess that's the way I describe it. In the back of your mind going, does this look like it's healing properly or not? Does this look like it's trouble? It's and people tell you things. When you see something that doesn't look severe and people are in extraordinary pain or just don't feel right and it just isn't getting better, say, I was here earlier and I got to come back because this doesn't feel right. It's not because they want attention. Okay, you have to deal with drug seekers and people who want attention. There's all sorts of conditions. You familiar with the term Munchausen's disease? Or Munchausen's by proxy? Oh, it's time to learn that. Munchausen's are people who are constantly coming in. It's worse now with this stupid thing. Oh, I think I got this. And they want attention. I think I have Sjogren syndrome. Oh, no. You don't look pregnant. No, I have no idea. I mean, they tell you the stupidest things because they want attention. They think they've read it on the internet. Oh, I'm imagining I'm having this. That's Munchausen's disease. One's worse is when they bring their kids in. because they want the attention. Oh, I have a terribly sick kid. Oh my God, he must have cellulitis. His skin's red. You know, you know what it looks like? He was playing with cherries you had in the refrigerator. Oh, really? You know, do you get the idea? Occasionally, and as you haven't discovered by now in your relatively young ages, there's a lot of people who are crazy. I was going to say a word, F and nuts, but I'm not going to do it. And I'm sure you have discovered this. You know, elevator, top floor, 2 fries short, Happy Meal. Isn't that expression you use? I don't know what you say for people who are crazy today, but we were a couple of French fries short of a Happy Meal. I had to be careful about squirrels in the fall. Gather nuts. Certifiable. Why am I talking to myself here? Gram-positive cocci, drive on the skin, coag positive. Staph epidermidis is the most common cause of healthcare associated infections, period. Staph aureus causes serious wound infections more commonly. Staph epidermidis is not a big time player. You've done enough gram stains. Multiple virulence factor, all of those things we looked at before with skin infections, enzymes that do tissue clumping that allow proteins to attach, the coagulase, the capsule, okay, evades immune system, spread from abscesses, super antigens, etc., that are there. Not as virulent, okay, typically not a problem. Tiny suture abscess, we take out the stitch. If it's around the staple, we take out the staple. It's not a big deal. Clean it up, put steri strips on it. You can buy steri strips at Walmart. Okay, the big problem with them, biofilms. Staph epidermidis is hard. They make a lot of biofilms. And again, I told you with antibiotics, there's certain antibiotics that do. That's why I used a lot of clindamycin, because it could penetrate the biofilm despite the side effects that were there. Okay, it's hard. They may be ineffective. Bacteria may come loose and be carried by bloodstream to other tissues. All of these types of things. These people who are in the hospital, you have immunocompromised people, people whose immune systems are not just because they're taking immunosuppressive drugs. They're older, they're sicker. That's who's in the hospital. Hospital's not a good place to be. Terribly saying, if you're very ill, yes, but if you're going to see more and more the trend, outpatient care, limited time, and keep people just like they do in any emergency room up to 24 hours before you have to admit them. They're still technically an emergency patient. You can observe them. Okay? We don't want to put them in if we don't have to. And then we're going to talk about the monetary aspect. Increased risk of surgical wound infections. All of these are there. It's normal. Opportunistic immunocompromised. Here's the different ones. Thorough cleaning of wounds, reduce infections. Certainly do. I cooked this up just to show you, even though most of the time it's group A streptococcus, relatively rare, as I told you before when I talked about it in passing, it is relatively easy to treat, and it just needs to be treated, but it does need to be recognized. Most people don't see it because streptococcal infections cause something called cellulitis and start to spread. And necrotizing means it's basically everything between the skin and the bone is getting gobbled up. It's a microaerophilic that produces a lot of gas bubbles in the process of doing this. All these different things, childbirth fever, this fasciitis, toxic shock, there's all sorts of things potential. But it's almost as though and they showed one of those on the pit, but I had seen enough. I had seen a couple of cases. I knew what it was, and I knew what they were emphasizing. This is one of those. It's one of those you can easily misdiagnose these. Put a knife in and everything just spreads apart, and yuck comes out. Liquid, pasty, necrotizing is turning it into a liquid goop, for lack of a better term. Not pretty. The key to this is called subcutaneous emphysema. Again, emphysema is trapped air. And so when you see subcutaneous emphysema, and that's why you take a scout X-ray. I don't know if people think, oh, we got to get a scan for this, scan for that. X-rays are easy. You don't need somebody major. You can get film back up the patient, sent electronically very quickly. So it's trapped air, or in this case, trapped gas, generally CO2, under the skin. If you see that when there's a wound that looks angrier and the patient's sicker than maybe you think they should be, you better, get a surgeon down and take a look at that now. If they have that, they're probably lucky to get away with an amputation. That's how fast. That kills quicker. Biggest thing we're seeing that with is people injecting themselves, particularly anabolic steroids, bodybuilding things, illegally acquired drugs, because they do it in unsanitary ways. IV drug users, less so. They're pretty. I hope this doesn't shock you. When they go out and buy heroin from a dealer, they generally get needles as part of the package. It's like going to Walmart. Oh, you get this and this with this little kit to addict yourself to drugs. Does that shock anybody as much as it shocks me? Fulminant means it goes super fast, suddenly it progresses, and if it progresses, again, you're lucky to get away with an amputation. That's there. There's different ones that are there. The pain, it's like all that gas and fluid is pushing and the skin won't give. It's intensely painful. Okay. Discolors the skin, fever, confusion without treatment. Yeah, you're going to die. Again, beta hemolytic gram positive, Lancefield group A, all these different spreading and protein gobbling up. Okay, proteolytic enzymes, DNA enzymes, breaking down red blood cells, streptococcal pyrogenic. Again, these are, one's a super antigen here, another one destroys a variety of tissue, all of those things. And the end product, unfortunately, is this. It's there. Very few do we see this in the US. And then these are risks. Diabetics, I saw one in, and I saw one in a drug abuser. Only 2 cases. All of these other things are part of it that are there. And I said, again, with people injecting themselves. There was a very interesting article. I have a few minutes to tell you. I cooked it up. So we will get to tetanus and the next time we meet. As I cook this up here, I saw an article about that on one of the news sites. And it came from Florida, but they reported because it's a fresh eating. This is a Vibrio. We see it around the water, and the most famous Vibrio, it's a comma shape, and it's called cholera. And it's a terrible disease, war-torn, contamination, post-major disasters, etc. The biggest, really, people die more from diarrheal diseases after a disaster or at wartime than they do from the incident itself. So that's why we're so cognizant of water, potable water, antibiotics, those kind of sanitary conditions. Flesh-eating bacteria, warm coastal brackish. Those are water. Brackish is kind of yucky. The other thing that is in Florida with brackish water that you want to avoid are these large fellows called gators. That's my policy in Florida. Stay away from that water because you might have company, and the company is not pleasant. That was within 200 yards of where my grandkids were in Florida on the golf course, on the naval base. Hey, that was where they lived. So the kids were warned, we are not going over into the golf course to play. Right in good old Mayport outside of Jacksonville. But look at this, 31 cases and 5 deaths in 2025. Open wounds, shellfish, neck fash, that's how we refer to it, all of those things. And these are little things: brackish water, open wounds, cuts, piercings, tattoos that haven't healed, immediate attention. And this is where, St. John's that's where Jacksonville is, by the way. Bay, Broward is down that's Fort Lauderdale area. Lee is Fort Myers. For you Florida fans. See if I'm about done with everything else for you. I know. And then let's do the Pseudomonas then, because that's birds. I don't want to short shift it. All right. Ciao. Goodbye. 2 more of these to put up within a final. You should be celebrating. I'll be celebrating.